Okay, we're going to touch on some areas in Chapter 16. So if you pay attention to your objectives for this chapter, you'll see it's really not specific towards the medication so much as to being able to identify some of the disorders and developing teaching plans and applying the nursing process and so forth, and being able to differentiate between different types of disorders in adults. Causes that can lead to PTSD or some type of physical or emotional abuse that has happened, or neglect, or maybe someone who's been witness to some type of typical violence that's very traumatizing. Children who are starved for affection may be vulnerable and confused by sexual abuse. Last time we'll see repetitive play about the event, some social withdrawal, decrease in play, maybe negative emotions, may blame themselves or think negatively about themselves. The reactive attachment disorder will see emotionally withdrawn in the social world and towards their caregivers. This is usually caused by a lack of bonding during the time before 8 months of age. The disinhibited social engagement disorder, patients don't show a fear of strangers and are not bothered by separation, and they're usually willing to go off with people they don't even know. The comorbidities that we normally see with these trauma-related disorders are nightmares, lack of trust, along with some types of phobias, impulse control, somatic, and identity issues. Also, with these, usually they are very vulnerable to developing or exasperating symptoms such as they're like PTSD. They also will suffer overwhelming nightmares or have difficulties with trust, as well as I said before. Learning and attention problems can come up, behaviors problems, sleep disorders, depression, suicide attempts, substance abuse, or also some other types of comorbidities that you may see. Under the psychological factors, there's an attachment theory, and it describes the importance of creating a relationship and bonding early on. If they've shown studies where children who were not bonding with the parents, only wrapped up in a blanket but never held, never have learned to attach to someone. Environmentally, factors, resilience not established at an early age due to some kind of lack of support relationship and attachment can also lead to the trauma-related disorders as well. Going through the nursing process on the assessment, sometimes there's a developmental delay that can be noted. Type of data collected depends on the severity of the problems that were presented, resources that may be available, and assessment should always be ongoing throughout the treatment. It's best assessed by a observation, interaction, kind of a semi-structured interview to find out about any current problems or issues in developmental history, and this can include their maturational level. Is it appropriate? Play activities are best to use with the young children, and there is a systems assessment data. It's the last full paragraph on page 308 in your textbook. Number one is impaired parent-child attachment, and the second biggest diagnosis you're going to see is risk for delayed development under your nursing diagnosis. So impaired parent-child attachment would be the first one, and the second would be risk for delayed development. Your outcome identification. Outcome is for the patient and child or the infant to demonstrate some type of affectionate relationship. And then as our nurse is working with these patients, they are mandated by law to report any type of abuse or suspicion of abuse to Child Protective Services. Treatment can include psychobiological, psychological, and family goals. Safety and stabilization and creating this warm, safe environment are also part of the implementations that you want to start. Also, having them stop any kind of destructive behaviors and educate them about the effects of the trauma. For the traumatized child, it is important to get moderate arousal out of them, but you don't want them to stay within a window. But you want them to stay, you want them to stay within a window of tolerance. So there are some modules that can be seen on page 309 talking about some of these. Something else you want to think about is family therapy, group therapy, play therapy, mutual storytelling, maybe games, drawing, as well as deep breathing and mindfulness techniques are some of the interventions that can be used. Meds work best when they're usually combined with some type of cognitive behavioral therapy, and even an eye movement desensitization and reprocessing can also be very effective. When we evaluate, safety is always to be maintained, and we want to make sure that continues. We also want to reduce their anxiety and stress, appropriate behavior and emotions to certain situations. We want to make sure that they are meeting those milestones, and that's meeting their developmental milestones, and seeking adults for nurture and help. We are seeing more and more patients with PTSD. So with PTSD, as a child, post-traumatic stress disorder is the same as and characterized as it is in adults by this persistent experience, some type of traumatic event that they play over and over, and the individual, becomes very fearful. They feel helpless and horrified by what they've experienced. Some examples could be those who have been in military combat, maybe someone being a prisoner of war, natural disasters, human disasters, crimes, especially very violent crimes, and also some type of life-threatening illness may also cause that. The symptoms usually can begin about a month after the exposure, but sometimes it can be delayed by months or years in some individuals, so that may not, but that's usually not an uncommon thing to see as well. When they're re-experiencing, they're having what we call the flashbacks, and sometimes there's avoidance, and that's avoiding any type of stimuli associated with the trauma. So someone who may have been in combat doesn't like to go to the fair where they shoot off fireworks. As I said, with PTSD, it can have a long lag, and screening should always be ongoing for someone who has been in this type of situation. Persistent symptoms can be that they're irritable, they have insomnia, lack of concentration, maybe exaggerated startle response, and these can come out of the blue. And again, they can also have an alteration in their mood, such as chronic depression. With adjustment disorder, as you can see here from these bullets, the nurse needs to build trust and show compassion in the face of a lot of these adjustment disorders. Therapeutic responses are going to provide these patients with comfort, and the nurse should show patience and tact while offering a lot of warmth and sympathy to the patients. The epidemiology and comorbidity for this is that more than twice the number of women are affected than men who develop PTSD. And some of the comorbidities include, again, anxiety, depression, sleep disorder, and dissociative disorders. They have difficulty with social and interpersonal and maybe even occupational relationships, while trust seems to always be the common denominator. I mentioned dissociative disorders on the previous slide, and so when we talk about these are disorders that occur after some type of adverse event or experience that's very stressful, and so they will actually develop some type of unconscious defense mechanism to protect themselves. So then when we think that when they have this separation of emotional and these anxiety that affect them, they'll actually just have a disturbance in their memory, consciousness, self-identity, and their own perception. They have an intact reality testing, so that what that means is that they may have flashbacks or images, and they're triggered by current events, but they relate them to the past trauma. And so disassociation is involuntary, and it results in a failure of normal control over their mental processes and how to integrate conscious awareness. And these dissociative disorders are on the next slide. They're depersonalization and derealization disorder, dissociative amnesia, and then a dissociative identity disorder, also known as DID. So here are a list of your disorders that I had mentioned. And so look these over. Depersonalization, derealization disorder is the individual focuses on themselves. They're uncomfortable observing their own body. The focus is on the outside world, so they feel their surroundings are unreal or distant. With derealization, this is a focus more so on the outside world. So when they go through derealization, they have recurring feelings that their surroundings are unreal and distant, and so they may feel mechanical or dreamy, or maybe even a little bit detached from themselves or from their own body. When we think about dissociative amnesia, this is an inability to recall personal information, where they've been. Often it's from something traumatic or stressful in nature. So they have a lack of memory because the information is just too pervasive for them to recall. It's too hurtful or painful. Things about themselves they can't remember. Sometimes they can't remember for a period of time where they've been and who they are. So that can be actually very, very unnerving for these individuals. Dissociative identity disorder, also known as alternative personality, and so they have an alternate personality that has its own pattern of actually relating to others and thinking about themselves and their environment and how they perceive themselves and others. So it's usually two or more distinct personalities that recurrently take over and control the individual's behavior. So with dissociative disorders, you can see your bullets here. It is some of the comorbidities that we will see with this is depression, panic attacks, eating disorders, PTSD, somatoform disorders, OCD, reactive attachment disorders, attention deficit disorders, substance abuse, borderline personality disorders, sleep disorders, sexual disorders, you name it. So it definitely may be morbid with conversion disorder or even personality disorders as well. With the dissociative disorders, some of the psychological factors is usually they have more of a primitive ego defense mechanism, and with environmental factors, it's usually from some type of acute overwhelming trauma that can trigger. I went ahead and went over the information for this slide, which is the definitions that I gave earlier, so please make sure to refer back to those. With dissociative amnesia, they're not able to recall personal information around some type of event or traumatic event that's happened. If someone goes into what we call a dissociative view, they can't recall their own identity or information about some of it or some of or all of their past. Also, what's interesting about this one is that during this state, they may tend to live their lives, move on, but however, when they can't recall their own identity or information about some of all their past, so sometimes they'll even just assume a whole new identity because they can't recall who they are or where they've been. If you ever saw the movie Sybil, and then there's also that was in 1976 with Sally Field. It's an excellent movie. It's very intriguing. Another one that's more, I guess maybe up to date for y'all is Me, Myself, and Irene, made in 2000, which is another one about different personality disorders, DID. So very interesting. Nearly all patients with DID have some type of history of child abuse or trauma, and that is what's called it. And with Sybil, we found out that she had a very traumatic and abusive child life, which brought on all these different personalities. One of the things that you want to do is clarify their history and course of past symptoms or events in their life. You want to get a clear picture of any current physical, mental, and their safety status. You also, many times, they're misdiagnosed with just depression, schizophrenia, or borderline personality disorder. As far as their moods, they're very anxious, depressed, or unconcerned. So they have mood shifts. When the alternate identity takes control, the mood will change. During the fugue states, patients' new identities function adequately by choosing simple, undemanding jobs, have a few intimate social interactions. DID patients have family and work problems, is what we see during these fugue states. For depersonalization, patients fear others will see them as distorted, and they try to avoid being seen in public. And that can have a huge impact on the family. They may have thoughts of suicide, so we do have to make sure we keep their safety up front, and number one. So on the self-assessment, nurses may be skeptical, maybe even uneasy to interact with these individuals. And they can even get caught up in the intrigue of these patients. Trust occurs very slowly, and medical records can be used as a court exhibit if needs be. Look at tables 16.1 and 16.2. 16.1 is on page 319, and 16.2 is on page 320. Psychoeducation, you want to normalize experiences by explaining that their symptoms are really adaptive responses to past events that were overwhelming. Grounding techniques are taught to make them more aware of noticing things that are real in the present, to counteract episodes. Pharmacologically, there's no specific meds. Now, we can give antidepressants, anti-xylotics, antipsychotics can be prescribed for those hyperarousal or any kind of intrusive symptoms that they may have. During the crisis intervention, it's important for us to stabilize our patients. And again, psychotherapy can be used to help to improve their situation to a state that is more level and functionable.